Good evening, respected teachers and dear friends. Am I audible?
Yes, you are. You are audible.
Okay. Thank you, Rajit sir, for that exciting talk on xenotransplantation, its new aspects and prospects, which have been very interesting. And now let's move on to the topic, that is anticoagulation in CKD patients with atrial fibrillation. So, chronic kidney disease, as we all know, there are lots of heart rhythm disorders which we encounter daily in our dialysis patients and non-dialysis patients with CKD. That is atrial fibrillation, flutter, supraventricular tachycardias, ventricular arrhythmias. And we know that many of the patients with chronic kidney disease, they die due to coronary artery disease or arrhythmias and leading to sudden cardiac death. So, atrial fibrillation is one of the most common arrhythmias, and the lifetime AF risk is very high, 23% for women and 26% for men at age 40. And in atrial fibrillation, as the kidney disease advances or the renal function deteriorates, it's more and more incidence of atrial fibrillation with more and more risk of CKD progression. And as we all know, chronic kidney disease and AF, they share some common risk factors like age, male sex, obesity, then smoking. Then there are systemic processes like inflammation, oxidative stress, fibrosis, and all these can. So there is a bidirectional link between chronic kidney disease and atrial fibrillation. And you can see that when you consider patients with chronic kidney disease with atrial fibrillation and without atrial fibrillation, the mortality is very high for patients with atrial fibrillation. It is more than 25%. So in this talk, we'll be discussing about the prevalence, whether to anticoagulate or not, what is the risk, and what are the newer agents, and what are the guidelines say. So this slide is interesting because the incidence of AF or prevalence of AF in chronic kidney disease patients is around 15 to 20%, and you can see that CKD in AF patient is around 40 to 50%. So when you consider chronic kidney disease population, the importance is that they are at a risk of high thromboembolic risk. Whenever you have a patient with chronic kidney disease, atrial fibrillation, the first thing that we consider is the thromboembolic risk. And at the same time, these patients are at a high risk of hemorrhagic risk also. So this population is high risk. While the patients have high hemorrhagic risk, as we all know, there is alteration in the platelet synthesis, composition, and activation. There is dysregulation of the prostaglandin metabolism and thromboxane H2. And there is dysfunctional platelet vessel wall interactions and reduced platelet aggregation. So all these factors will predispose such patients for increased bleeding risk. And apart from that, there could be patients patients will be having concurrent antiplatelet use or NSAID use and anemia, platelet vessel wall interaction, and all these factors will predispose the patients for reduced platelet aggregation, making the patient more vulnerable for bleeding. So we have to consider these patients as a group where there is high incidence of high risk of thromboembolism as well as hemorrhagic risk. And there is a prothrombotic state which is coexistent in AF and CKD, and there are vessel wall or atrial tissue abnormalities which are by the vascular factors. There is accelerated atherosclerosis, endothelial dysfunction, then atrial fibrosis. Then there are blood flow abnormalities like blood hypercoagulability state and increased thrombin antithrombin complex, and there is platelet dysfunction, which is increased aggregability and increased reactivity, and all these factors will predispose. And there is abnormal kidney specific mechanisms which underlie the high burden of atrial fibrillation among patients with CKD, like effects on cardiac structure. Whenever there is abnormalities in the mineral metabolism, that itself can predispose, and effects on endothelial function leading to premature atherosclerosis, and effects on the functional and vascular calcification, this low-grade inflammation, and increased activity of the renin-angiotensin-aldosterone system and the renin system are all related with leading to incidence of atrial fibrillation in chronic kidney disease patients. So what happens? What are the consequences of AF in chronic kidney disease? One is the first and most important is the risk of stroke, which is elevated in both dialysis and non-dialysis patients with atrial fibrillation. And as I said, there is a bidirectional link between atrial fibrillation and chronic kidney disease. And CKD increases the risk of incident AF, and it also predicts new low onset GFR, low GFR, and proteinuria. It also increases the risk of progression to ESRD. And as we all know, there is associated with increased mortality in chronic kidney disease. And different types of AF, whether it is paroxysmal, persistent, or permanent AF, all predispose to subsequent ischemic stroke, and the risk is around 4 to 5-fold. And diagnosed AF is responsible for at least 15 to 20% of all ischemic stroke. Even subclinical AF increases subsequent risk of stroke to 2.5-fold. So when you have a patient with chronic kidney disease with atrial fibrillation, the first thing is what are the options that we have? We have vitamin K antagonists like warfarin, and then the non-vitamin K antagonists, also called newer or novel oral anticoagulant agents or direct oral anticoagulant agents, which is the topic of interest today. That is the dabigatran, rivaroxaban, apixaban, and edoxaban. They are the newer oral anticoagulant agents or novel oral anticoagulant agents. So this we all know there are different types of molecules. Direct vitamin K antagonist and as I said, direct thrombin inhibitor and factor Xa inhibitors are there, like rivaroxaban, apixaban, and edoxaban. And in patients with following clinical settings, like patients with thrombocytopenia or non-coagulation defect, or patients with active bleeding or recent surgery or prior history of IC bleeding, or patients with combined use of anticoagulant and antiplatelets, all these patients are at a high risk of bleeding. So when these patients, when we have these molecules like dabigatran, which is a direct inhibitor of thrombin, then rivaroxaban, apixaban, and edoxaban, they are the factor Xa inhibitors. So many of these molecules, we know that among these molecules, apixaban is the one which have been studied in some patients with end-stage renal disease, like of stage 4 or 5 CKD, and we'll come to that later. So when you have a patient with atrial fibrillation and chronic kidney disease, we have to determine the stroke risk, and importantly, we have to determine the bleeding risk as well. For determining the stroke risk, we have a score that is CHARTS-VAS score, where we have to do the scoring system to identify what is the risk of a patient to have a stroke. And we have to consider oral anticoagulation if score is more than or equal to 1 in males or more than or equal to 2 in females. And similarly, we have a bleeding risk also called Hash blood score to determine the bleeding risk. So after we'll come to that later. And after assessing the score, stroke risk and the bleeding risk, we have to identify and we'll know the creatinine clearance and what are the drugs that we can use. And one other important aspect of these options, that is oral anticoagulant options, is whether vitamin K antagonist or novel oral anticoagulants is the time in therapeutic range. That is how much time patients will have in the detectable, especially with vitamin K antagonist, we will have to do serial monitoring with BT-INR. And this time in therapeutic range means, or what is the percentage of time in which patients have this acceptable therapeutic range the INR value falls. As we know, with the novel oral anticoagulant agents, we don't have to monitor with INR, and the different dosing system have been is mentioned here. With creatinine clearance more than 50, the dose of apixaban is 5 mg BD, dabigatran is 150 mg BD, edoxaban is 60 mg OD, and rivaroxaban is 20 mg OD. And once the creatinine clearance falls less than 30 ml per minute, apixaban dosing is 2.5 mg BD. Dabigatran is also half the dose, 75 mg BD. Edoxaban is 30 mg OD, and rivaroxaban is 15 mg OD. As you can see here in the end-stage renal disease population, the only studied molecule with some data is only apixaban. The dose is 5 mg BD. About dabigatran, edoxaban, and rivaroxaban, we don't have data. So all these patients, even if we start with oral anticoagulants based on the stroke risk and bleeding risk, we will have to address frequent bleeding risk factors, frequent follow-up, and they have requires monitoring of the renal function. So what is the disadvantage of vitamin K antagonists? We have been using warfarin since many years, and as we know, warfarin requires initial bridging with heparin, and there is a relatively unpredictable pharmacokinetics and pharmacodynamics. And many times patients will be either undercoagulated or sometimes will be over anticoagulated. And so the time with their in a target INR ratio is spent. There is less time in the normal or acceptable INR range. And there could be increased number of the bleeding episodes. And as we all know, there could be anticoagulant-related nephropathy, like warfarin nephropathy. And patients should be compliant with the drug, and there requires strict diet interactions could be there with the drug. These are the disadvantages of vitamin K antagonists. So when we consider the novel oral anticoagulant agents, it has a more predictable effect by directly inhibiting the activation of coagulation factors in the later part of the coagulation cascade. They have a more rapid onset of action. No bridging is required. It has a shorter half-life, can be given in a fixed dose without the need for monitoring, and they lack diet and drug interactions. So when you have a chronic kidney disease patient with atrial fibrillation, this is the scoring system for assessing the stroke risk assessment. That is CHARTS-VAS-2 score. That is, C is congestive heart failure, H is hypertension, A is age more than 75 years, D is diabetes mellitus, S is history of stroke or transient ischemic attack, V is vascular disease, A is age more than 65 years, and S is female sex. So you can see that two values have been given 2 points each, that is age more than 75 years or history of previous stroke. They are given 2 points each, and all other factors like age more than 65 and all other factors are given 1 point each. So all patients with in males, if it is more than or equal to 1, or females, if it is more than or equal to 2, patients should be considered for oral anticoagulants in the absence of contraindications. That is the scoring system for risk assessment for stroke. And this is the bleeding score risk, that is Has-Blood score. And H is uncontrolled hypertension, A is abnormal renal function, S is history of stroke, B is bleeding or history or predisposition, L is labile INR, E is elderly, D is drugs, that is antiplatelet agents, NSAIDs, etc. And this Has-Blood score, each value has been one has been given 1 point each. And if it is more than or equal to 3, it indicates that patients could develop increased risk of oral anticoagulant-related bleeding. But we cannot, that is not a reason to deny the use of oral anticoagulants, because we have to prevent the ischemic stroke. So this is the score, but we have to be cautious and we have to monitor the patient. That is the basis of this Has-Blood score. We can identify patients who are at a high risk of bleeding. So there have been various trials which have been done in the among the novel oral anticoagulant agents versus warfarin in patients with AF. These are the Reliance trial, which was done with dabigatran, Rocket AF trial, which was done for rivaroxaban, Aristotle for apixaban, and Engage AF TIMI was done with for edoxaban. So you can see that in all these trials, there have been more than 15,000, almost 15,000, more than 15,000 of patients were included in the study. And you can see that all these patients, the stage 4 and 5 CKD have been excluded. At renal function exclusion criteria was less than 30 ml per minute. And what was the study? It was the baseline normal dosing of these molecules were studied in this versus warfarin. And the study results were for the Reliance trial with dabigatran, there was a lower rate of stroke and systemic embolism and similar rate of major hemorrhage. And with the rivaroxaban also similar rate of stroke and major bleeding. And for Aristotle trial with apixaban, it showed less stroke and major bleeding, which is important. And Engage AF TIMI trial also showed similar rate of stroke with major bleeding. So from this trial, we can see that only apixaban showed a less stroke and major bleeding among these trials. But that was also till stage 3 CKD. So, since apixaban was tried, I'll show the renal AF trial, which is apixaban and is an effective anticoagulant compared to vitamin K antagonist. So this study was done in dialysis patients. So I said earlier in the previous slide that all these patients, the CKD category up to 3 were included, 4 and 5 were excluded. So since we have to know what is the importance of atrial fibrillation in the dialysis population, and this renal AF trial was in patients undergoing hemodialysis, but it is a small study and it was done in USA among 154 patients undergoing chronic hemodialysis with atrial fibrillation. They were monitored for a period of almost 1 year. They were 2 arms, one apixaban arm and warfarin arm. And you can see that there was a bleeding risk. That is 32% risk for apixaban and 26% for warfarin. And the important thing is the stroke or systemic embolism 1-year event rate was 3% in apixaban and 3.3% warfarin. So now you can see that in the end-stage renal disease or the dialysis population, there was almost a 10% increase, tenfold increase of bleeding risk when you compare the stroke prevention rate. So the clinically relevant bleeding were tenfold more frequent than stroke or systemic embolism among patients with atrial fibrillation and end-stage disease on anticoagulation. That was the importance of this study, which renal AF showed that anticoagulation in dialysis population for atrial fibrillation for the prevention of stroke or systemic embolism has a substantial risk of bleeding for such patients. So where we have to consider whether they have to be anticoagulated or not. And this bleeding risk could be major bleeding, IC bleeding, or gastrointestinal bleeding. So we have to consider what is the recommendation for such patients. So end-stage renal disease is the a systematic review and network meta-analysis, which was published in AJKD. So it was a meta-analysis of 8 RCTs and 46 observational studies in patients with later stages of CKD, including dialysis patients using oral anticoagulants, and it had a participation of around 1.7 lakh patients. And there was a pairwise meta-analysis between direct oral anticoagulants versus warfarin, and whether oral anticoagulants are required or not, means versus no oral anticoagulants. And there was different among the oral anticoagulant, direct acting oral anticoagulants, there was a network analysis also, Bayesian network meta-analysis among the different oral anticoagulants. So what were the results? So among when you compare direct oral anticoagulants and warfarin, it was found that this paired meta-analysis showed that in AF patients with GFR 15 to 60 ml per minute, there was a decreased thromboembolic events risk of around 14%, and there was a decrease of 19% bleeding events risk in when you give the direct acting oral anticoagulants compared to warfarin. So directly acting newer agents were better for reducing the thromboembolic events and bleeding events risk in patients with GFR up to 15 when you compare with warfarin. And but in patients on dialysis, the results were similar to renal AF trial, which showed that there was an increased bleeding events risk. That is more than 28% increase in the bleeding events when you give oral anticoagulants in AF patients on dialysis. And in AF patients, when you compare the different types of newer oral anticoagulant agents like apixaban, rivaroxaban, dabigatran, etc., the dose-adjusted apixaban seems to be superior to other direct-acting oral anticoagulants. That was in patients with GFR up to 60 ml per minute. So in dialysis patients, there was an increased bleeding risk even in with newer agents. So as we all know, many of our dialysis patients or non-dialysis patients, CKD patients with atrial fibrillation will be treated by our cardiology colleagues, and they will be seeing not KDIGO, but they will have to see what AHA, ACC say, and let's see what is the AHA and ACC recommendation for such patients. For patients with AF who have a Charts-Watts score of 2 or greater in men or 3 or greater in women who have end-stage kidney disease or who are on dialysis, it may be reasonable to prescribe warfarin to keep an INR of 2 to 3 or apixaban for oral anticoagulation. That is the AHA guideline. That is for patients with end-stage renal disease or on dialysis also, either warfarin or apixaban. That is the AHA guideline. And in AF or end-stage kidney disease on dialysis, direct thrombin inhibitor or dabigatran or other molecules like rivaroxaban or edoxaban are not recommended. This is the AHA guideline for this anticoagulation in such patients. So we know that there is a lacking of RCT data on anticoagulation, and from what KDIGO has advised is warfarin could be given to maintain an INR of 2 to 3 could be considered in up to GFR of 15, that is stage 4 CKD. And in dialysis patients and non-dialysis patients, we have to see the risk-benefit ratio and decide. And apixaban 2.5 milligram per hourly BD is the only drug which is advisable in dialysis patients also, and the stage 5 CKD non-dialysis group also. And dabigatran, edoxaban, and rivaroxaban are not recommended. So when you have these anticoagulant-related anticoagulants for longer time, we have what is the function, what are the adverse effects which can affect on which can have on kidneys. So this is published in Kidney International. This is a community-based cohort study in patients who are treated with newly initiated atrial fibrillation therapy, and their adverse effects were monitored for 1 year. And these patients will be on either antiarrhythmic agents, rate control therapies, and warfarin or directly acting oral anticoagulants. And the adverse effects were monitored for the next 1 year. And the antiarrhythmic agents, hypotension, bradycardia, complete heart block, and like amiodarone, there could be thyroid disorders. Then with warfarin and direct oral anticoagulant agents, bleeding risk was studied. And here you can see the right-hand side, the results by eGFR. And we can see that as the eGFR declines, there is hazard ratio or the risk of having adverse renal outcome is increasing as the GFR declines. So lower eGFR was associated with significantly higher risk of adverse effects after initiation of commonly used therapies to treat AF. So that is one thing that we have to consider when you give long-term anticoagulation in chronic kidney disease patients. There could be adverse renal outcomes can also occur, and there could be anticoagulant-related nephropathy is one thing which can cause which is due to excessive anticoagulation with warfarin or other anticoagulants. It can occur in a setting of excessive anticoagulation, especially with INR more than 4. And it is pre-existing CKD is the strongest risk factor for anticoagulant-related nephropathy. And AKA in a setting of excessive anticoagulation, hematuria. And when you do a renal biopsy, you can see obstructing intraluminal RBC cast, which is the most conspicuous histologic features of anticoagulant-related nephropathy. And the incidence with warfarin, and some studies shows it is the incidence is around 20.5% overall, but 33% in patients with CKD. And other risk factors include age, diabetes mellitus, heart failure, hypertension, etc. So this factor also we need to consider. So patient has to be under regular monitoring for decline in GFR, if there is any doubling of creatinine and the kidney failure. All these factors we need to monitor. But it is mostly seen in patients who are over anticoagulated.
Sangeetha, it is time.
Also, 2 more slides only. So the recommendation for discontinuation, this is for just a slide for dabigatran and apixaban, the newer agents. When you consider before a procedure, when you have to stop the medicine, stop the oral anticoagulant before the procedure, one important thing is whether you have to see whether it is a low risk procedure, with a low risk of bleeding, or it is a high risk procedure with high impact of bleeding. You have to, here I have added whether how many hours before we will have to stop the drug. For dabigatran, for low risk procedure, if more than 48 hours, and for high risk procedure, we will have to stop it for more than 96 hours. And apixaban, edoxaban, etc. It should be like more than 36 hours for low risk and more than 48 hours for high risk population. So to conclude, in a patient with AF and chronic kidney disease, we have to assess the stroke risk, that is starts fast sore. And if it is a low risk patient, we can follow. If it is a high risk, as more than 1 or equal in males, more than or equal to 2 in females, you have to assess the bleeding risk and consider oral anticoagulant therapy, estimate the renal function, and as I said, for less than 15 group, that is ESRD, on dialysis or non-dialysis stage 5 CKD, we have either warfarin or newer oral anticoagulant agent, that is apixaban. These are the only drugs, but still another study which is frail AF, which is
Sangeetha, it is time, please. We need some discussion.
Yeah. So ideally there is to conclude, patients with CKD, stage 5 CKD patients with atrial fibrillation, there is insufficient data to recommend warfarin routinely for prevention of stroke. And since there are recommendations only is that apixaban we can give at a lower dose, that is especially in CKD stage 5 group. But warfarin, the problem is we will have to monitor with long-term frequent monitoring with PT-INR. But in apixaban, we don't have to monitor the patients with, but still the risk of bleeding is high in apixaban group. There is no RCTs to conclude that apixaban or the newer oral anticoagulant agents is better compared to warfarin, especially in dialysis patients. And all the oral anticoagulant agents have significantly high risk of bleeding in stage 5 CKD on dialysis group with atrial fibrillation. Thank you.